I will just suggest you that even if you, for example, if someone is targeting physiology or anatomy related to anesthetist, and there should be some clinical correlation, like what we are discussing since last 2 days. We are just trying to uh, have a basic concept of correlation between vitamin D, calcium, phosphate, and parathyroid hormone and calcitonin. So this is physiology. Okay. So similarly, the next step will be the disorders, and then what are the anesthesia implications? How will you interpret? How will you manage? Okay. So similarly, similar case is true for anatomy. So there is no separate anatomy, or there is no separate physiology, which you will open a book physiology and you are reading only physiology. If you will try to do it, it will not be that much fruitful if you are not clinically correlating it. Okay, so that's my message. Similarly, anatomy will be correlated with uh, really related to either some for example, anatomy related to regional anesthesia. You will be targeting the plexuses and the relative anatomy landmarks related to that nerve block. Similarly, you may be facing you have to pass some invasive lines. So similarly, anatomy will be related to that thing. Or like whatever you are just trying to understand related to anatomy should clinically correlate. If you are understanding an airway, you should airway like management, you should be knowing about the airway anatomy. Only then you will be able to understand where is cricoid cartilage, where is thyroid cartilage, and similarly. Okay, so there is no concept of studying physiology separately as a separate mosque. No, things should be correlated. Okay, so we will just continue from where like we stopped. So I just gave you a basic few points related to calcium, okay, and parathormone. So and I will just quickly recap that there is a parathyroid hormone which is trying to increase the calcium levels in the blood. So it will be doing it through effect on kidneys, through effect on bone, and indirectly through intestines via vitamin D. Okay, so I think this is Dr. Sadaf who asked me. Maybe I was confused. Anyways, so like whenever there is decreased calcium level for any reason, so parathyroid hormone will be trying to, this will be through activation of vitamin D and as well as increase reabsorption of calcium. And here it is demineralization through osteoclast activity, okay, via osteoblast, and intestine via vitamin D. Okay, so this is how parathyroid hormone will be acting. So similarly, calcitonin will be acting in increased calcium, and it will try to minimize blood levels. So it will be acting through osteoclast. Okay, so osteoclast activity as sorry, not osteoclast, osteoblast. Like osteoclast activity will be inhibited, and there will be increased mineralization. Okay, so it will be decreasing the calcium levels. So this is just a quick review, and now we will just try to have some aspects related to hypercalcemia. Sorry, hyperparathyroidism. I'm sorry. Okay. So again, like any other problem, it is mainly primary hyperparathyroidism, which is related to any hyperplasia, adenoma, cancer, or as part of multiple endocrine neoplasia, in which there will be primary increase in the secretion from the parathyroid gland, or it will be related to secondary. The secondary will be related to, for example, CRF, due to like any dietary malabsorption of either vitamin D or calcium in any condition in which it's not being absorbed. Okay, so so that will be related to that will be causing secondary hyperparathyroidism. Okay, so usually the clinical features are in kidneys. Okay, and there is a stone formation, and there will be decrease in GFR. Okay, and it will result in urinary concentrating ability loss. Okay, it will be resulting in polyuria. Similarly, this in skeletal osteofibrosis cystica, like it is eating bone. Okay, so there will be decreased bone thickness and increased absorption, resorption. So bones will become weak. There will be bone pains. There will be pathological fractures related to it. And in nervous system, there will be fatigue, loss of skeletal muscle strength, and mass of proximal musculature. Peptic ulcers disease may be due to calcium-induced gastric hypersecretion. This I was not clear about it. Zishan, do you have any idea about it? Peptic ulcer because of hypercalcemia? This was something new.
No, sir.
This was something new for me. So, like it will be resulting in hypercalcemia. Okay. So, differential diagnosis will be any neuroendocrine and endocrine tumor or some drug induced, because thiazide also cause hypercalcemia. Okay. So one thing that what will be the ECG changes in hypercalcemia, or you can say it is written here, but why it is QT? Like why it is affecting? Because we saw that potassium was affecting T waves. Okay, so where should hypercalcemia act? In the ECG or in the conducting cardiac muscle action potential? Because if you remember the plateau is because of calcium. Okay, so it should be affecting there. Am I right? So like it will be resulting in problems related to ST segment. So ST segment will become shortened, and it will result in also QT interval shortening. Okay, so maybe mimicking MI changes, like it will look like because there will be decrease in ST segment. So maybe T wave is coming just after QRS complex. So it looks like elevation. Okay, so it will look like, so this is how you should be thinking, that where it is occurring, like what is the role of that ion in the conduction pathway. So in the conduction list action potential, so it will be easier for you not to forget it about it. Okay, so I have just written, yes, what is the clinical correlation between calcium level and albumin? Zishan or anyone? Sumera, what is the relationship between calcium levels and albumin?
That day, Dr. Bilal explained about it, but I don't have a concept of it. There is a correction that we have to do with albumin.
No, but just basic concept is, yes, Sumera, can you tell?
If there is a hypoalbuminemia, there will be, I guess there will be increased free calcium in the blood.
So you have to correct it, because albumin is bound. Calcium is bound to albumin. Okay, so because when we measure actually total calcium. So actually, whenever there will be hypoproteinemia, you have to correct. You see, that's what they have written. For for every 5 gram per liter decrease, you will add 0.1 millimole per liter. For example, if it is 30 instead of 40 albumin, so you will add 0.2 millimole. So if the reading is 2, you will make it 2.2. Okay. So things like that, 2.2 millimole per liter. Okay. And because there is, if you are finding the etiology of hypercalcemia or say hypocalcemia, you should be also measuring phosphate, because when phosphate levels are increased, they will bind calcium and it will result in hypocalcemia. Similarly, if there is less phosphate, then calcium level will be increased. Okay. So similarly, they will be doing the like radiological or general investigation related to symptoms the patient has, bone scans and like evaluation, PET scan maybe they will be doing to see the whole body, any malignant condition is there. Okay. So if it is parathyroid, like primary hyperparathyroidism, that will be the treatment will be surgical. Okay. And they will be giving some medications which will be mimicking, which will be like counteracting the effects, for example, in bone. Okay. So what are the medication which they use? What is the name of that group of medications? Which are being used?
Bisphosphonates.
Bisphosphonates. Okay. It decreases the osteoplastic activity and it will increase the mineralization. Okay. So because it will, whenever there will be hypercalcemic crisis, there will be dehydration. So to counteract this, we have to correct the hydration status. Okay. And then bisphosphonate, this is palmidronate. I have never used it ever in my life, so I don't know how to use it. Calcitonin is also available. Calcitonin will also decrease the calcium levels. Okay. Life-threatening, rapidly loaded with phosphate. Maybe you may need to give some phosphate. So, and force saline diuresis. Like once like you have corrected the dehydration, the next step maybe you will be using diuresis to increase the levels of calcium. Okay. I don't know what is the role of hydrocortisone. They have written it. And hemodialysis. Whenever the end result will be, you can do hemodialysis. So surgical, parathyroid surgeries are usually like same concerns, similar to like thyroid. Like it will be neck surgery and there may be swelling or problems with the airway maybe there. Okay. Secondary hyperparathyroidism as occur in CRF. So Sumera, or anyone, if you can just revise, we had discussed yesterday, you were not here, but if you can, why there is, because this question may be asked to you in your Viva, that why there is hypocalcemia in CRF. So this question is exclusively for you. Yes, Sumera, can you hear?
Yes, sir. Sir, in renal failure, like kidney deal with the calcium.
Okay.
There is calcium absorption. I don't remember the exact part of the kidney where it is done. So in renal failure, that calcium reabsorption is impaired.
This is one reason, because this I'm just trying to ask the question which is related to you. Okay. So if you don't know, you should be knowing this answer. Just note it down and you can read about it. It will be related to, yes, Dr. Sadaf, you can tell. You were raising the hand. Zishan, would you like to tell, or anyone want to explain?
Sir, one of the reason is hydroxylation of the cholecalciferol that occurs in the kidney.
Not cholecalciferol, calcidiol.
125 dihydroxy. Yes, sir. The first one is in liver, that is 1 hydroxy cholecalciferol, and then the second hydroxylation is 125 dihydroxy cholecalciferol.
Yes.
So the second step occurs in the kidneys.
So Sumaira, this is the relation, that because for calcium absorption through the gut, vitamin D is important. Okay, so that's why, if you remember, they give vitamin D as well, because vitamin D is important for absorption of calcium. So one effect you were telling is one effect. So DCT effect is one of them, because it is being reabsorbed from DCT. So that's why with thyroid, which because they are affecting over there, it can result in hypercalcemia. Okay, and another thing is that this decrease in vitamin D will lead to problems related to hypocalcemia. This is one reason. The other reason is related to phosphate. Okay, so what is that relation, Sumaira? Can you tell?
Sir, I don't remember this time.
Okay, just think about it. Because kidneys are excreting the acids. Okay, so phosphate is, when phosphate will not be able to be excreted, phosphate will bind. Just now I told that phosphate will be binding to calcium. So that will also result in decreased ionized calcium. Okay, so this is related to hyperphosphatemia as well as absorption as well as vitamin D. So this will as a whole will result in this problem. Okay, so because you are here today, so I just wanted to ask the question which is related to you in because it's least likely to be asked as a separate parathyroid. Usually it will not come, but this question will be related to either thyroid gland, because when parathyroids are removed, for example, if they are identifying the parathyroid, Sumaira, what they do if they identify during thyroidectomy parathyroid gland, what they do?
Sir, during thyroidectomy, usually they spare the parathyroid glands.
Okay, so what they do then? They put it back. If they like it is removed, they put it somewhere in the body. They can, like, you under the skin, they put it, because it will autonomously then start secreting. Am I right? Anyone can correct me. Does it happen like that? If it is incidentally being, am I right? Who's telling?
No, I don't have any experience in it.
Yes, they put it back. So they put it back. So otherwise it will result in hypocalcemia. Okay, and sometimes it may also, even after removal, that result in tertiary hyperparathyroidism, because now the negative feedback system is, as you see, by the developed autonomous hypersecretion of parathyroid, causing hypercalcemia. The excessive parathyroid secretion continues despite correction of the underlying renal disease. This occurs in that way. Tertiary hyperparathyroidism absorbed most commonly in patients with chronic secondary hyperparathyroidism, and often after renal transplantation. They put the kidneys back, but this negative feedback mechanism or system will still be uncontrolled. Okay, so hypertrophied parathyroid glands fail to return to normal and continue to oversecrete parathyroid hormone. So this is what is tertiary hyperparathyroidism. Okay, so it's like that. The clinical manifestations of tertiary include persistent hyperparathyroidism after renal transplantation, or new hypercalcemia associated with chronic secondary hyperparathyroidism. Okay, so this is just related to it. And I forgot, I had read it, but I forgot if anyone knows this bone, groans, bone, something like that. There is a mnemonic or formula for clinical manifestation. Okay, I will just try to find it out.
Yes, sir. It's psychiatric moans, thrones, and
What is
bones,
thrones?
abdominal.
Thrones is
Sir, thrones mean increase urinary frequency, increase urinary, I think, frequency or flow.
and
And
this
then
bones,
stones,
pathological bone fractures.
moans, G sir, bones and moans is abdominal pain, and psychiatric there was also a psychiatric moans, I guess, like depression or anxiety or related to this.
Yes. So what will be the
Abdominal pain.
yes.
One is stone.
Yes, stones are also there because hypercalcemia or hyperparathyroidism will result in renal stones. Okay. So what will be the correlation? One is dehydration. Okay. Other is arrhythmias. What else? Anything else? So I think this one, as I told you, that neck exploration, if they are doing it, you can have superficial or deep cervical plexus block. Okay. And it may be related to this one. What will be the effect on neuromuscular blocking? Will there be any effects of hyper?
Yes, sir. Yes.
Prolonged effect?
Yes, sir. Prolonged effect because it decreases the neuromuscular excitability, the high calcium.
Okay, so that's the same concerns, reinforced tube. Okay, Sumera, this may be related to you. If they are asking this question, you should be knowing about these things. Actually, they are the same, like some of them are just like thyroid. So you see, they will be extending it. So if any cervical instability, that can be a problem, because when they make the exposure there, you see, they do extension. So it will be related to the tube can also dislodge. Tube will can come out. Okay, so we have to think about it. And what else? Methylene blue. Why methylene blue? Why
So it's
methylene?
used to identify
Identify of the gland. Yes.
the gland.
Yes. So it may be problem creating with the pulse oximetry. Okay. If it is associated with the renal failure, so you should be telling all the concerns related to chronic renal failure, because maybe you are only thinking about this one you are only thinking about parathyroid, so think about renal failure as well. Okay, and that's what I was confused. You see, I was telling wrong. It is antagonizing. Okay, so in hypercalcemia there will be less effect. There may be a possibility of decreased requirement. Okay, possibility of decreased requirement of muscle relaxant, although hypercalcemia may be expected to antagonize the action of non-depolarizing muscle relaxant. So
Yes, sir. That's why I told it. It basically decreases the neuromuscular excitability, so the effects are prolonged. So we should reduce the neuromuscular blocking agent dose.
yes, but you see, there may be inappropriate effect, inappropriate response. So it is better, preferable, when they are asking you this question, you have to tell that whenever there is anything in exam, especially in oral part, Sumera, do mention about nerve stimulator. Okay, nerve stimulator, and any condition in which there is any electrolyte imbalance, do ask about specific ECG monitoring. Even you can tell 5 lead ECG or modified leads. Okay, so this will be, they will be asking you, and positioning will be a problem. So you have to, because of osteoporosis, there may be bone fractures. So they are just telling you all the the possible complications. And whenever they are doing neck surgery, there will be things related to recurrent laryngeal nerve damage, or so you just think in that direction. Okay. Electrolyte imbalance, this hungry bones causing hypomagnesemia and hypocalcemia, or both. When they are like parathyroidectomy is done, after that there is exaggerated response. Okay. So as we face, we will just discuss about this hypoparathyroidism as well, but just it is related to sudden movement of calcium from the circulation. Okay. So usually it occurs, this hypocalcemia occurs after how much time usually? After this
24 hours, 24 to 72 hours.
Okay, and how will you treat it?
Sir, we will give the IV calcium gluconate.
Okay, calcium gluconate or calcium chloride you can give. What is difference between calcium?
Sir, we can. Sir, there is a total amount of the calcium. Like in calcium chloride, there is increased free calcium, ionized calcium.
So ionized calcium is
And in
more
calcium
in
gluconate,
calcium chloride. So if you
calcium
want
chloride.
rapid correction, it is better to give calcium chloride, because you will be giving less dose and it will have more effect. Okay, but you should need to give it slowly, because it itself can cause arrhythmias. So this is one thing. And what are how to identify hypocalcemia after parathyroidectomy?
All the signs, the Shostak sign, the Trozo sign.
Okay,
And there can be-
which test is more sensitive, Shostak sign or Trozo sign?
Trozo sign.
Yes, Trozo sign is more sensitive. Sumera, what is different? What do you mean by sensitivity? When will you say that this
Sir,
test?
in which there is chances of like this disease is more positive.
No, for example, if I say
Less false positive.
Usman, just let her tell that, then you correct it. Okay. So if you, for example, I say that this test, as I told, that Trozo sign is more sensitive for hypocalcemia than Shostak sign, what does it mean? Yes, Sumera?
Sir, to rule out any other cause.
No, this is not an answer, because this can ask you. I'm just intentionally asking this question to you because it will create a bad impression. Yes, now Usman, now correct her. If a test is more sensitive, what does it mean? Yes, Usman.
Sir, it means that it will. Sir, it means that it will give less false positive and more true positive.
Yes. So why are you telling false positive? Sensitive means if the test is positive, the chances of disease are more. That's it. You don't need to tell about negative. This is for specificity. Okay. If a test is negative and there are chances that disease will not occur, that test is more specific. Okay. If a test is more sensitive, it means that if it is positive, there are more chances of having that problem. This is called as sensitivity. And if it is, for example, if you do a test and you say that it has that much sensitivity and that much specificity, so it means that if this test is positive, there are more chances of that disease. And if this test is negative, there will be, if the test is very specific. So ideally, we should have a test which is very sensitive and very specific. But actually, usually, though both combination does not occur in every case. Okay. Understand, Sumera? If a test is positive, so you will say it more sensitive if positive test will result in the disease more. Okay. And if you have a negative test, so you can say by surety that if this test is negative, it means there is less chance of that disease. So it means that that test is more specific. Okay, so that is how
Okay,
we.
sir.
So, because this they can ask you in any like question related to long case, so you should be knowing about it. Okay, so so now hypoparathyroidism, it may be inadvertent removal or it may be congenital. Okay, so there will be low ionized calcium and then it will be resulting in like opposite. So it is this irritability, perioral paresthesia, restlessness, and neuromuscular irritability, stridor, fatigue, muscle cramp in chronic conditions. So we usually we correct it with the calcium gluconate or calcium chloride, and then if it is like slowly, you can give through oral route as well. And consideration will be yes, one thing I forgot. What is the relationship between alkalosis and acidosis? Yes, Sumera. What will effect of acidosis or alkalosis on calcium levels? If you have
Sir,
a
in acidosis,
yes,
there will be I
there will
don't
be
remember
more.
exactly, like,
There will be more free calcium.
yes.
Okay, the binding will decrease with acidosis, and binding will increase with hyper ventilation, or you can say alkalosis. Am I right, Usman?
Yes, sir. And I would like to add something. Hypercalcemia causes acidosis and hypocalcemia causes alkalosis.
How it is? How it happens?
Sir, exact mechanism, I don't know. I have read somewhere that increased calcium causes acidosis and decreased calcium causes alkalosis.
Okay, so just for a concept, it is fine. But in the exam, never say the word which you don't explain. Okay, you don't tell it is better, but they whenever you will say commit anything, you should be knowing the reason. Okay, so
So effect of acidosis and
Albumin.
alkalosis of calcium is similar like on potassium.
I'm sorry again.
Yes, but sir are asking the exact mechanism.
But because they can ask you, na? I don't remember this thing. So I will suggest you, for especially suggestion for you, Sumera, that you tell the thing which you know. If you don't tell don't know, don't start the discussion yourself. Okay,
Okay,
because
sir.
especially in long case, in long case, it is just like in cricket, there is a free hit. So examiner can ask you anything. So try to be dictating your viva yourself, because next question they will be asking, because in their mind there is some questions, some aspects they are asking you, but usually some of the questions will be directed by your answers. Okay, so try to be meticulous. This is also a tip, not to say the thing. And these small things, Sumera, you should be knowing, because in the exam, whenever they are asking you and anything related to CRF, because CRF will be there in hypertensive patient, it can be there in diabetic patient, it can be there. So you should be knowing. And these questions, if they ask, you are prone to forget. So it's related to hypoalbuminemia, anything, it will affect on a number of things. So you should be knowing what is the effect of certain condition on certain things. Okay, so this is
Okay, sir.
just yes. So similarly, as I told you,
Okay, sir, I have found the explanation from Google.
yes.
Sir, it's written hypercalcemia causes reduced GFR, increased sodium excretion, and depletion of total body water, leading to increased bicarb reabsorption and metabolic alkalosis.
Okay, yes, fine. This is the reason exactly. Okay, so and this is what is important about it. We will inshallah and any questions, please, anything you want to discuss about this. And Usman, do you remember any other question related to it? Anyone has anything related to it? Okay, so inshallah we will
This calcium.
Yes, you see, these are, I will share these charts with you. And you know, because Dr. Sadaf, you are here, I will, Dr. Sadaf is here or left? Anyways, so thank you very much, and inshallah we will continue our discussion related to this Pandora's box. Okay, thanks a lot. Assalamu alaikum.